Okay, anyway, shall we start? Today's my talk is to continue the operation technique for Oxford UKA. So the previous lecture, I explained about the osteophyte removal from until to the ACL insertion to the tibia plateau, and then lateral outlet or intercondylar notch, and then detach from the PCL on the medial condyle, femoral condyle, and the medial edge of the medial condyle, and then between the medial condyle and MCL. So then, after the preparation of the osteophyte removal, this is a very important point to mark the surgical cut position using the cut tray that can be a saw blade guide in the further step of the surgical bone cut. Then the next should be the sizing. Sizing is made using the spoon gauge that should be placed at the center. In other words, the lowest point at the bottom of the condyle, femoral condyle, and measure the radius of the posterior condyle, because a posterior condyle is similar to the circle, like this. But other times, it's very important to make sure there is some space between the edge surface of the femoral condyle and anterior edge of this spoon gauge, because this point should be placed at the articular surface before the osteoarthritis. So this space should be the thickness of the cartilage. It should be normally the 2 millimeter in thickness. And make sure there is some space, 2 or 3 millimeter space between the edge and articular surface. If then twist the spoon gauge, if the spoon can be twisted more than 20 degrees in each direction, so please replace to the 2 millimeter or 3 millimeter spoon gauge instead of the 1 millimeter spoon gauge, and make sure the stability. This should be not too loose, but not too tight. It's very important. After the insertion of the spoon gauge, place the tibial cutting guide in front of the tibial crest. Place the proximal part of the tibial cutting block just medial to the patellar tendon. Or you can see some dip or defect of the this defect should be on the patellar tendon. This rod should be the parallel to the tibial crest, both coronally and sagittal. But in fact, in the coronal, the alignment on the coronal plane is decided by the lateral rubber band, distal rubber band on the ankle, and proximal cutting block just medial to the patellar tendon. Naturally, the rod is placed vertically parallel to the tibial axis on the coronal plane. To adjust the sagittal plane to make the parallel between the tibial crest and the tibial rod, please use your fingers to move your fingers the upper word to the lower word to make sure that you can feel this rod is placed parallel or not. Normally, there is a space for the two fingers from the upper end to the lower end. We say it's the two finger technique. It's quite important. If you set the tibial rod in the parallel to the anterior crest of the tibia, the cutting block is placed at 7 degrees in posterior slope. Then fix the G clamp to the spoon. So connect the spoon and cutting block using the Z clamp. So push down the lever and fix securely and make sure if the spoon is placed at the bottom of the medial femoral condyle and block is placed just medial to the patellar tendon, and the rod is parallel in both coronal and sagittal plane. Then fix using a pin, headed pin, through the most lateral hole. Otherwise, if you use these media to holes, you will make the fracture after the surgery. Never use these holes. Please use only the most lateral holes. Then make sure the cutting block is placed properly or not. So for this purpose, insert the Z retractor to just below the meniscus, and between the MCL and the medial femoral condyle, medial tibial condyle. Sorry, and then down your eyes at the surface of the cutting block, and make sure this cutting line is protected by the Z retractor. So during the surgical cut, the MCL should be protected by this protector. So if this protector protects the MCL or not, you can see your eyes. You can make sure using your eyes. It is quite important procedure. And sometimes you can't insert a protector between the medial tibial condyle and MCL. At that time, I recommend to detach the part of MCL just width of the protector. So detach the MCL to protect the MCL, to insert the protector between the medial tibial condyle and MCL. It is quite important because to retain the original tension on the length of the MCL is quite important. So the tension on the MCL is essential in this operation. Then replace the shim from the non-slotted one to the slotted one. To stable and flat bone cut, I strongly recommend you to use the slotted cutting guide. Then replace and pick the cutting the slotted shim to the cutting block using this towel clip. Is really nice. And then cut make the horizontal cut. Before the horizontal cut, make sure the direction of the sagittal bone saw, the horizontal bone saw. It should be the battery parallel to the sagittal bone cut direction. It should aim to the ASIS anterior superior iliac spine. So I recommend to use a saw twice. The first one should be directly posteriorly from a little bit lateral side and go straightly posterior side. And it is quite important you should feel that the saw cut the posterior cortex. You can feel some friction or resistance, and then you feel this, how can I say it? Some reduction of the friction. So that implies the posterior cortex is cut completely. If you stop the bone saw before the cutting of the posterior cortex, then during the removal of bone plate, you can make the fracture around the posterior cortex that can cause the instability or some loosening of the tibial tray. So again, it is quite important to cut the posterior cortex completely. But at other times, again, you should make sure there is enough space between the pop recess area to the leg holder. So sometimes leg holder push the pop recess area anteriorly. In this condition, you can hurt the neurovascular. It's quite dangerous. So before you cutting the tibia, you should make sure there is a space between the pop recess area to the leg holder. Then next, to drive the saw along the medial plateau edge. So like this is the first time is just a posterior, and the second along the medial plateau edge and cut the cortex of the medial tibial condyle. It is quite important. And sometimes this medial cut is incomplete. In this case, some bone protrusion exists on the cutting plane that can cause the malalignment at the tibia. So again, you should cut completely from anterior to the posterior along the medial cortex and along the protector. Then next is sagittal cut. Sagittal cut is very difficult and very dangerous. Again, you should make sure the space between the leg and leg holder, and then put on your bone saw, sagittal bone saw, just medial to the top of the medial tibial spine, that where you already made some slot using the cartridge. So this slot can prevent the medial saw slip. Then put on your sagittal bone saw, just medial to the top of the medial tibial spine. And then bone saw should aim to the ASIS, anterior superior iliac spine. Then cut the tibia, the firstly anterior part, because the anterior side is very hard. It is quite difficult, and anterior half of the tibia cutting plane is you can see the precisely where you are cutting. So then you cut the anterior part of the tibia plate, and Then you make sure again this direction is correct or not. If you make sure the direction is correct, you drive the bone saw posteriorly. At that time, never hand up, never lift up the driver. Otherwise, you can cut the tibia deeply in the posterior side that can cause the fracture after the operation. Aim to the ADIS and never hand up. That is quite important in this procedure. If you're worrying about the too deep saw cut, I recommend to insert another saw blade between the bone fragment into the horizontal bone cut plane. That can prevent the deeper cut. So anyway, it is quite important, and sometimes it can cause error. I believe the most complication is caused by the sagittal cut error. For example, too medial cut can cause the overhang of the tibia tray and sometimes cause a fracture, because if you implant the tibia tray to medial, the keel can close to the medial cortex that can cause a fracture after the surgery. So, and in contrast, if you cut the sagittal cut to lateral, you can hurt the ACL and even PCL. That can also cause the severe complication after the surgery. Then, after the removal of bone fragment of the tibial bone plate, medial tibial condyle plate, at that time, I recommend to put out this bone fragment using the two clamps and pulling and push and pull. Okay, but sometimes if the patient has the intact, purely intact insertion of the posterior root of the medial meniscus, that can prevent the excision putting out of this fragment. At that time, you gently pull this fragment anteriorly, and then you can find the intact medial meniscus root. Then you cut the root of posterior meniscus. And other difficulty is caused by the osteophyte, especially around the PCL insertion area. At that time, unfortunately, you can put out the bone fragment with the fracture of the posterior part of the bone plate. But don't worry, you can remove this bone piece later after the posterior condyle cut. Anyway, after removing the bone plate, then you should evaluate the flexion gap. So to evaluate the flexion gap, insert the femoral draw guide using 2 fingers. If it is smoothly inserted using your 2 fingers, it implies the thickness is enough. The thickness should be similar to the thickness to the tibial base plate and polyethylene, thinness polyethylene. So that should be the 3 millimeter and 3 millimeter equal 6 millimeter. At that time, we need at least 6 millimeter. Otherwise, you should enlarge the flexion gap at that time. So there is the 2 ways to enlarge the flexion gap. The one is remove the posterior cartilage from posterior condyle of the medial femoral condyle, because normally the thickness of posterior cartilage is 2 millimeter. So if you cut the cartilage completely from the posterior cortex, you can get a 2 millimeter bigger pressure gap. But sometimes, even after the removal of the posterior condyle cartilage, the gap is still tight at that time. You should recut the tibia. But I don't recommend the recut tibia because that can cause the loss of bone mass to the tibia side. It is quite dangerous for the patient with a very small frame. And recut can cause uneven cutting surface that can cause the instability or the loosening of the tibia side. So then make the proper entry point for the IM rod. IM rod should be inserted just medial to the center of the intercondylar notch. At the times, make a line at the center of the trochlea on the lateral edge of the medial femoral condyle. I think the center point of the two lines should be the best point to insert the IM rod. And the firstly, insert the drill guide, and then enlarge this drill hole using the chisel, owl using the owl. Ideally, the rod is inserted using the two fingers is very smoothly. If the direction of drilling is proper, you can insert this rod with a very light touch using only the two fingers. But sometimes this direction is incorrect, or sometimes the IM canal is very narrow and the femur is bowed. So as a case, you should impact the rod. You using your palm or even using the hammer, but it must be very gently. Otherwise, this rod can penetrate the bone cortex that can cause unnecessary damage of soft tissue and make the malalignment, especially for the femur side. But do not use the hammer as much as you can. Then, placement of the femoral guide is also important. That should be placed at the center of the medial femoral condyle. So using the linkage, connect IM rod and drill guide. In this condition, this drill guide is placed 7 degrees in valgus in the coronal plane and 10 degrees in flexion in sagittal plane. And another important thing is this should be placed at the center of the medial femoral condyle. So before the placement of the femoral drill guide, you should draw the center line on the surface of the medial femoral condyle. After the placement of this femoral guide, you should look the surface of the femoral condyle. At the time you can see the line of the center line of the medial femoral condyle through these drill holes. If the line is placed at come to the center of this hole, this implies this drill guide is placed at the center of the femoral medial condyle. In another way to place this one at the proper position, you pinch the both sides of the medial femoral condyle using your 2 fingers, your thumb, and your index finger, and you can feel this drill guide is placed at the center or not. So you carefully place this drill guide at the center. Again and again, you should make sure that it is placed at the center or not. Then insert the drill. The first is narrow one, and the second is bigger one. Ideally, this 2 hole is vertical perpendicular to the tibial cutting plane and at the center of the medial femoral condyle. But this hole is placed, this a bigger one should be at the center of the femoral condyle, medial femoral condyle, because this one is sometimes a little bit medial side because medial femoral condyle is slant laterally slightly. So so we can allow this the smaller hole is placed a little bit lateral side. We can accept it. So using the fingers, using 2 holes, insert the drill guide like this. Okay, this is the end of my talk. Later, I will continue my explanation of this technique in the next week. Thank you for coming. See you next week.